Good morning. I'm Richard Thomason, Director of Policy at Blue Shield of California Foundation. I want to thank the Children's Data Network and the American Professional Society on the Abuse of Children for having me here today. For almost 2 decades, Blue Shield of California Foundation has partnered with organizations, leaders, and advocates throughout California and across the nation with the goal of ending domestic violence and advancing health equity. We know that domestic violence affects more than 2 intimate partners. It affects children, extended families, and entire communities. Every year, 1 in 15 children are exposed to domestic violence before age 14. To break this multi-generational cycle, we focus on healing and on directly addressing its root causes. This means especially focusing on prevention solutions that address the diverse needs of communities of color and families with low incomes. As we work with many of our partners to end the cycle of domestic violence, we want to effectively track health and domestic violence outcomes to support learning that drives action and equity. One of our goals is to strengthen the responsiveness of public and private sector systems to meet the needs of the communities most affected by domestic violence. That's why we were pleased to fund the Children's Data Network and the University of Southern California School of Social Work to link state government administrative program data in ways that help us better understand how Child Protective Services reacts to reports of intimate partner violence. Later in this webinar, Dr. Revy from USC will present her findings from this research. What I appreciate about all the articles in this special issue is that they help improve understanding of the intersection of child maltreatment, child welfare systems, and intimate partner violence. A number of articles shed light on critical questions regarding policies and practices for how child welfare systems deal with intimate partner violence. These articles demonstrate a point that Dr. Grasso makes in the introduction to this special issue. We need much more crosstalk and collaboration among systems that come into contact with intimate partner violence, including Child Protective Services, victim advocacy services, and court-based batterer intervention services. We're working towards the day that all systems that touch survivors and their children work more effectively and equitably to meet their safety and health needs and offer the types of resources that create substantial opportunities for healing and building resilience. We look forward to today's presentations and to learning more from all of you. Thank you again.
Welcome, and thank you for this important discussion of research on the intersection of intimate partner violence and child maltreatment. I am Stacy LeBlanc, and I am currently serving as the president of APSAC, the American Professional Society on the Abuse of Children. I'd like to start this morning by welcoming all of you and join me in recognizing and expressing our appreciation to the Children's Data Network Blue Shield of California Foundation for providing this free half-day event on the special issue of child maltreatment. I also want to thank all of the authors and editors and our staff and team and board members and Dr. Vince Pelusi and Bart Klicka and so many others who've come together to make this a reality. I want to thank also our facilitators today, Carla Stover, Daniel Whitaker, and Damian Gracio. I also want to thank our APSAC board for joining me in voting to make this special issue free access. Child maltreatment and intimate partner violence, as we all know, routinely overlap and they address so many common risk factors and co-occurrence in the same family and system and households. We now recognize them as adverse childhood experiences with intergenerational effects and common and compounding complex adverse effects across the lifespan. Research in this area continues to move the field forward, and this special issue does this in a unique way and helps to further the mission of APSAC, which is to strengthen practice with knowledge, and here today on topics related to child maltreatment and IPV. These articles, I really enjoyed being able to look over. I just got my issue in the mail. I hope all of you have yours, or you can access it. We will put the link in the chat so you can access it for free. But it has truly been a delight to see how much time and effort has been put into this and to help us to improve practices and to further the evidence into the varied and intricate and unique ways that these form of family violence co-occur. The authors in this special issue provide compelling rationales for the ongoing need to investigate the co-occurring forms of violence when individuals, to screen, to address parenting issues as they arise, and as we see them in these families, whether it be family nurse home visitors or or within the new legislation to allow for home visiting to address these issues that keep arising. There's so many concrete, practical advice within this issue to improve policies and practice. So I want to make sure that you, if you're not already a member of APSAC, that you join us at APSAC. We have a number of events coming up. I would like to extend an invitation to all of you. As a board member, I have the ability to give a discount code of 20%. You can use my name, Stacie, STACIE 20, as a discount code, and I hope you will join us at APSAC. I also want to invite all of you to join us live in New York for Live from New York. It's APSAC, December 14th and 15th. We have many fun events, including a walk together across the Brooklyn Bridge, seeing a play with colleagues, and breaking news that I get to announce right now to let you know that we have an additional opportunity that you can register for a full day to add with nationally acclaimed speakers addressing the mental health crisis that many of our children we serve are facing. And that will be on December 13th. The event is free to members. And if you're not already an APSAC member, please use the code STACIE20 and join us. Also, please don't forget to submit your proposals by November 18th to join us in New Orleans, my hometown, for the 29th APSAC Colloquium, where we will be celebrating the 35th year of APSAC. So if you haven't already heard, APSAC is in an incredible growth stage. We have reached more individuals in training and registration in the last year than we have in the 10 years prior, and we have doubled in our membership. We continue to serve and provide opportunities for all of you. So if I can be of any assistance, please reach out. With that, thank you for being here today, and I'm going to turn it over to our facilitators.
Hi everyone, my name is Samantha Brown and I'm an assistant professor in the Schools of Social Work and Public Health at Colorado State University. I will be sharing information about our recent publication titled The Co-Occurrence of Child Maltreatment and Intimate Partner Violence in Families, Effects on Children's Externalizing Behavior Problems. It is well established that child maltreatment and intimate partner violence often co-occur in the same family systems or households and have harmful consequences on children's health and wellness. In fact, children exposed to parent-to-child violence, including physical and psychological abuse and neglect, as well as the presence of intimate partner violence, place children at increased risk of developing externalizing behavior problems, which may in turn affect future adverse outcomes and perpetuate cycles of violence. Because child maltreatment and intimate partner violence, or IPV, have historically been treated independently in relation to prevention and intervention, the purpose of our study was to integrate these forms of family violence by understanding how child maltreatment and IPV cluster together to identify subgroups of children exposed to co-occurring forms of violence and investigate which subgroups of children may be at increased risk of externalizing behaviors. To address our research aims, we conducted secondary data analysis using the National Survey of Child and Adolescent Wellbeing, or the NSCA. The NSCA-2 is a longitudinal data set of children and families investigated for child maltreatment in the U.S. Specifically, data were collected across 3 waves, at baseline and 18 and 36 months post-baseline. For this study, we used a subset of the sample, which included children ages 1.5 to 17.5 years old and who remained at home with their biological mother at baseline assessment. The sample was selected because it aligned with our variables of interest. For example, majority mothers completed questionnaires regarding their experiences of IPV. Due to developmental differences in the timing and effects of family violence, data were subsequently analyzed according to developmental stages, which included early childhood, middle childhood, and adolescence. Our variables of interest include family violence indicators of IPV and child maltreatment, as well as children's externalizing behaviors. IPV was measured using the physical assault items from the Conflict Tactics Scale 2. Child maltreatment was measured using the neglect, physical assault, and psychological aggression items from the Conflict Tactics Scale Parent-Child version. Children's externalizing behaviors were measured using the Child Behavior Checklist, preschool and school-aged versions. This table shows more detail regarding our sample of children. For the overall sample, most families were low income and racially and ethnically identified as white, followed by Latinx, Black, and other race or ethnicity. There were nearly equivalent males and females. For all age groups, children's externalizing T-scores were on average below clinical levels across all waves of data collection. For our primary analysis, we first conducted latent class analysis for each developmental age group to examine co-occurring patterns of child maltreatment and IPV. On the right side of this slide is the individual indicators that make up each class. And although a little challenging to differentiate on this slide, each class is designated by a specific color. The 4-class solution was identified as the best fitting model in early childhood. 8% of children in early childhood were classified into the high family violence class, represented by the black dashed line. These children were characterized by high proportions of multiple types of maltreatment and IPV, as well as more and less severe forms of IPV. For example, mothers reported IPV that escalated to a partner hitting, slapping, or choking them. 43% of children in early childhood were classified into the low family violence class, represented by the orange dashed line. The majority of children were classified into this class and experienced less family violence except for verbal discipline. 36% were classified into the child physical abuse and psychological aggression class, represented by the green solid line. These children were more likely to experience multiple forms of maltreatment. Finally, 13% of children in early childhood were classified into the partner and child physical abuse and child psychological aggression class, represented by the purple dotted line. This class was characterized by a higher proportion of children experiencing physical types of IPV and maltreatment, as well as psychological aggression, such as threats to be hit by a caregiver. The 3-class solution was identified as the best fitting model in middle childhood, which included the same classes as in early childhood with the exception of partner and child physical abuse and child psychological aggression. 11% of children in middle childhood were classified into the high family violence class. 51% were classified into the low family violence class, and 38% were classified into the child physical abuse and psychological aggression class. The 3-class solution was also identified as the best fitting models in adolescents. 11% of adolescents were classified into the high family violence class. 46% were classified into the low family violence class. 43% were classified into the child physical abuse and psychological aggression class. Next, regression models were fit separately in each class. In each class, Wave 2 and Wave 3 externalizing behaviors were regressed on Wave 1 externalizing behaviors and the participants' gender, race and ethnicity, and poverty status. Regarding key sample characteristics, there were several nuances in each model, but in general, we found that the relationship between gender and externalizing behaviors emerged across developmental age groups within the same class, whereas differences in externalizing behaviors by race and ethnicity was impacted by class membership. We found that children in early childhood classified in the high family violence class had higher externalizing behavior scores at Wave 2 compared to their counterparts classified in the partner and child physical abuse and child psychological aggression class. Children in middle childhood classified in the high family violence class had higher externalizing behavior scores at Wave 3 compared to their counterparts classified in the low family violence class. Adolescents classified in the child physical abuse and psychological aggression class had higher externalizing behavior scores at Wave 2 than adolescents in the high family violence and low family violence classes. In summary, findings indicate that distinct classes of family violence may remain somewhat stable across development, but their impact on externalizing behaviors may uniquely impact children. High family violence or polyvictimization is evident as early as the preschool years, which may in turn have harmful effects on behavioral outcomes over time. As such, there is a critical need to address multiple forms of family violence in the context of child and family serving settings. This information could be used to enhance screening practices to not only obtain information regarding initial maltreatment reports, but also to assess other forms of family violence that may co-occur within households. This may require improved interagency collaboration, such as employing liaisons that work to bridge child welfare, healthcare, and the judicial systems, as well as home visitors to recognize multiple family violence factors and provide integrative services rather than to work with families in isolation. Effective strategies would further benefit from a deeper look into distinct forms of family violence, in addition to the promotion of protective factors within families and communities. Building on the strengths of families may help to prevent future maltreatment and IPV exposure and reduce the impact of children's health and developmental outcomes. With that, I will thank you for attending our session and acknowledging my co-authors, Drs. Rhodes, Marty, and Lewis, as well as funding that supported this work. Please feel free to contact me with information provided on this slide for any follow-up questions. Thank you for your time.
Hi, my name is Brianna Free, and I'll be talking a little bit about my and my colleagues' research published as part of the special issue in Child Maltreatment. Intimate partner violence, or IPV, and child abuse can both be conceptualized as betrayal-based traumas, or traumas perpetrated by a close other. Survivors of IPV often report histories of child abuse, and both of these traumas are associated with negative mental health consequences. Some researchers have even noted that IPV exposure during adulthood may exacerbate the impact of prior child abuse. As well, variations or patterns of exposure to these traumas have been noted in the literature, though mostly in children experiencing polyvictimization. Identifying patterns of exposure to child abuse and IPV over both developmental periods may inform screening and assessment protocols. So we first identified patterns of child abuse and intimate partner violence, specifically physical and sexual abuse during childhood, and physical, sexual, and psychological abuse in adulthood. Then we examined associations between patterns and mental health conditions, specifically PTSD, depression, substance use, social phobia, and GAD, as well as number of mental health diagnoses. Participants included 467 women who were over the age of 18, and these women were seeking help following IPV exposure. We used clinician-administered interviews to measure severity of mental health conditions, and we used responses on self-report questionnaires to identify patterns of trauma exposure. And we did this by using latent class analysis and M+. We then conducted Wald tests and post-hoc-Z tests to compare mental health conditions across classes. And we identified 3 classes based on statistical fit as well as interpretability. And the first class was characterized by experiencing each form of IPV and child abuse. The second class was characterized by experiencing each form of IPV without child abuse. The third class was characterized by experiencing psychological IPV alone, and this made up about 9% of our sample. With regard to mental health outcomes, the IPV plus child abuse class reported the highest levels of each mental health conditions. Relative to the psychological IPV only class, the IPV plus child abuse class and the IPV only class reported higher levels of both PTSD and social phobia. As well, relative to the psychological IPV only class, the IPV plus child abuse class reported higher levels of depressive disorders. As well, the IPV plus child abuse class reported higher levels of severity of substance use disorders relative to the IPV only class. And lastly, the IPV plus child abuse class and the IPV only class reported more mental health diagnoses relative to the psychological IPV only class. Results support a pattern identified in prior research characterized by both child abuse and IPV that's associated with increased mental health concerns, which underscores the need for greater attention to these betrayal-based traumas occurring in childhood and adulthood. As well, a pattern of women experiencing each form of IPV emerged, and interestingly, this class did not differ from the IPV plus child abuse class with regard to PTSD, depression, or number of mental health diagnoses, and this suggests that attention should be paid to women who have experienced both child abuse and IPV, as well as women who have experienced each form of IPV. And these results highlight potential dosage effect of IPV with and without child abuse. Lastly, a pattern of victimization characterized by psychological IPV was noted, which highlights the importance of screening for this type of IPV, given that it represented about 9% of our sample of help-seeking women. Overall, results point to the need for careful assessment of mental health in women who are seeking help following IPV exposure in an effort to improve identification of mental health needs as well as treatment. Thank you.
Hello, I'm Dr. Jessie Coe, and I'm going to discuss our recent paper entitled Cascades of Risk Linking Intimate Partner Violence and Adverse Childhood Experiences to Less Sensitive Caregiving During Infancy. So parental intimate partner violence, also known as IPV, conceptualized as physical, sexual, or psychological abuse by or toward a romantic partner, puts children at risk for experiencing maltreatment. However, little is known about what underlying processes and early risk indicators explain the link between IPV and risk for child abuse and neglect. Looking early on in the lifespan, maternal sensitivity during infancy, characterized by the mother's capacity to accurately interpret and respond to infant cues, provides the foundation for positive parent-child relationships across the lifespan and can also be an early indicator of parents' risk for engaging in child abuse or neglect. We know from prior research that experiencing IPV in pregnancy is a significant risk factor for less sensitive maternal parenting behavior during infancy. So in this paper, we were interested in testing a potential cascade model that may explain why this link exists. First, IPV has consistently been identified as a salient risk factor for depression, and some research suggests that this link may be especially significant during pregnancy. In turn, mothers with a history of depression may be more likely to feel high parenting stress. So this means that they may feel really overwhelmed by the demands of parenting. Then, when mothers feel heightened stress about their new role as a caregiver, it may undermine their ability to engage in sensitive parenting with their infant. Furthermore, women with a history of adverse childhood experiences, commonly referred to as ACEs, including abuse, neglect, household dysfunction, and parental loss, may be especially vulnerable to experiencing depression during the perinatal period. And a history of ACEs may exacerbate links between IPV and depression. Participants for this study were drawn from the PD study and included 295 racially and ethnically diverse mother-infant dyads who were primarily living in low-income contexts and were assessed prenatally and at 12 months postpartum. Mothers reported on their IPV, ACEs, and depressive symptoms at the prenatal visit. Then at 12 months postpartum, mothers reported on 2 dimensions of parenting stress. First, perceptions that the infant and interactions with the infant don't meet their expectations or aren't enjoyable. So that's this parent-child dysfunctional interaction dimension of stress. And also parental distress, which refers to just general feelings of distress that stem from personal factors directly related to parenting. And sensitive parenting was coded by trained raters during a mother-infant free play task. Path analyses in IMPLUS revealed that even after controlling for a number of sociodemographic covariates, including assessments of ACEs, IPV and depressive symptoms at 12 months postpartum, as well as some of these other factors you can see here, we found that prenatal IPV was associated with greater depressive symptoms in pregnancy, which was in turn related to both dimensions of parenting stress at 12 months postpartum, and then specifically parenting stress around parent-child dysfunctional interaction was associated with less sensitive parenting. And we did find that indirect effects of intimate partner violence on sensitive parenting through depressive symptoms and the specific dimension of stress was statistically significant. When adding in the interaction term between IPV and ACEs, we see that the path from the interaction term to depressive symptoms was statistically significant, and this indirect effect on sensitive parenting was also statistically significant. Understand the nature of the interaction between IPV and ACEs, we parsed the interaction using simple slopes analyses. And as you can see from the figure, IPV was significantly associated with prenatal depressive symptoms when mothers reported high ACEs, so that's this red line, but not when they reported low ACEs, so that's this blue line. Furthermore, we did find that the indirect effect of IPV on sensitive parenting was significant only when ACEs were high, not low. So our findings may have important clinical implications for promoting maternal and infant health and reducing risk for future child maltreatment. So first, an initial step may be to screen women receiving perinatal care at OBGYN clinics for multiple risk factors, including IPV, ACEs, and depressive symptoms, given that each of these risk factors are rarely asked about simultaneously, yet their combination launches a cascade of risk for poor health outcomes and future parenting difficulties. These findings may also inform the development and refinement of evidence-based interventions for maternal depression and for infants living in contexts of risk. This work would not have been possible without our community partners, funding support, and all of the participating families. And for more information on our study, be sure to check out the full paper in the special issue of Child Maltreatment on the intersection of intimate partner violence and child maltreatment.
All right, hello everybody. I'm Dr. Carla Stover. I'm one of the associate editors for this special issue of Child Maltreatment, and I'm a faculty member at the Yale Child Study Center. And I'll be facilitating our Q&A for this part of our panel discussion. So I'm really pleased to have heard the presenters talk about their papers that I got to read and help think about as we put it in the special issue. So please put your questions in the Q&A. There's a couple questions in there so far. So for our authors, I'll be sort of calling out questions. Some of them may be directed to specific authors or some may be more generally for the group to respond to. So the first question that came up in the chat had to do with the accuracy of self-reports. And I actually had a question about this too. How accurate are self-reports, particularly for things like the conflict tactics scale parent-child, if a mother is reporting on her own behavior of child maltreatment or physical abuse? And I think Samantha, that would probably be going to you, but others certainly, if you had self-report measures, you can chime in as well.
Yeah, I think it's a great question. I think there's always a concern for social desirability bias when someone's reporting on abusive or neglectful behaviors. However, I think in the context of the data set that we used, so the NSCA data set, which was a sample of families who were involved with child welfare, that often in child welfare settings, maltreatment most often gets categorized as neglect. And that covers just such a broad range of maltreating related behaviors. And so I think that in this context that the self-report can be kind of an additive and beneficial to be able to get at more nuanced types of maltreatment that might be occurring within the household. So I think obviously the best approach is to have corroborated information at multiple levels, but in this case, having mothers report on physical or psychological aggression related types of maltreatment might add to the categorization of neglect types of maltreatment.
Good. Anyone else want to say anything about that before I ask the next question? Okay. All right, the next question is regarding crossover between ACEs and maternal depression. So I think this is going to be for you, Jessie. In the context of IPV, could the depression have existed prior to the IPV?
Sorry, I had to find the mute button. That's a great question, and certainly very likely. Unfortunately, in this study, we did not have assessments of depression prior to the study, so we don't know about lifetime history or anything like that. I will say the measure we used in particular was asking about depressive symptoms I believe in the last 2 weeks. So you're right, it would have been excellent if we can control for depression prior to pregnancy, prior to experiencing IPV. We know that ACEs is commonly linked to maternal depression, and we did assess ACEs here. I will say links in this sample between depression and ACEs and IPV are pretty robust. So I would say even if there is some pre-existing depression there, we do find that, this assessment is quite strong. So we have reasonable confidence that at least part of that association, may be happening beyond just depression that was present before then. So maybe not a super satisfying answer to your question. I think it's a great question and one that we should continue to think about. But yes, that is where it stands here.
It looks like we have a follow-up question to that, Jessie. Do you work with the primary care or the PCP when looking at depression and ACEs screens in the past?
Yeah, so as part of the larger study, believe we did get access to PCP records. I'm trying to recall, I'm not the PI of the overarching study, and I'm actually not in academia anymore, so I'm trying to refresh my memory. We have not been able to look at that data yet, because when you're getting physician records, especially when the pandemic happened and kind of threw a wrench in getting access to everything, that is on the horizon for us to look at as part of the larger study, but we didn't have access to that data at the time.
Okay, great, thank you. All right, next question. This is for all the panelists. Can the panelists talk about some of the key policy and practice questions that should be high priority areas for research?
I'm happy to jump in just in terms of relative to the findings from our study. I think that, one thing that we didn't really have the luxury to do is look at how these classes evolve across development. So the classes were a snapshot at baseline and then predicting externalizing behaviors over time. And so I think in terms of next steps for research, seeing how those classes evolve across development for the same groups of children. And then I also think that linking those specific classes to other health risk behaviors will be really critical in order to inform prevention and early intervention. I think at a policy level, a lot of our conclusions from all of the presenters today were really focused on how do we get these agencies to communicate with each other so that we're not working with families in silos. And so thinking about, advanced training for like home visitor programs, or maybe it is in primary care where staff and professionals are able to both assess IPV and child maltreatment risk. And then at the same time that they might be screening for those, having specific resources that they can then link families to so that we ensure that their needs are being met. So those are just some of the initial ideas that come to mind.
Others?
Yeah, I think what Sam or Samantha, sorry, I don't know what you go by, did a great job touching on the big ones. I mean, personally now, I'm in the home visiting world now, and I see a bunch of implications there from a policy standpoint. I think you're right, primary care has a huge role here, especially if we're thinking about, with my paper specifically with perinatal care, doing a better job of comprehensive screening. Your point about communication between agencies and providers, I think, is huge, and something that's definitely been lacking. So basically, I think Sam's answer was great. So.
Great. All right. So there's a follow-up question, Jessie, back to the PCP question. So I think the question was more about, do you talk to the PCPs for patient care? So I'm assuming it means in the context of your research project, was there talk with the primary care physicians? I'm assuming about the data, but Suzanne, if you want to add more clarity to your question, if you're out there, please feel free to. Okay, so she's saying the network of care helps bring everyone together. So I guess the question is more about like the context of the research. Was there feedback going to the PCPs based on the data collection, or was the project separate?
Yeah, so this project was separate. So the larger study was a HRSA funded study, really interested in looking at, what's the impact of home visiting on a bunch of these outcomes. So this was kind of a secondary analysis. So as part of the main aims, there wasn't a big focus on just of the larger project of active communication with PCPs. I think that would be a great project. I would be excited to see that. And I think it is really important. I think that's a great question. But no, that was not one of the main aims of this study in particular.
I think so. I'll ask a question that's sort of related to that. And this is really actually for both Brianne and Jesse about this idea of screening. So I think you both sort of talked about that as potential implications of your findings about screening either in OBGYN offices or screening, in other places. And so I'm curious about this idea of screening both for exposure, right? Like that's one thing, but then I think there's a lot of pushback in the field about just screening for have you had ACEs or have you had IPV without then a follow-up of are you actually having any symptoms and what kind of intervention can we then connect you to, right? Like when you ask primary care providers, at least I've run into this, to just screen for something, that there's a lot of anxiety about, well, if I know about this, then what am I going to do about it? So I don't know if you have any thoughts or recommendations about how we might move that forward in terms of getting either mental health screening or other aspects of depression screening in these primary care locations.
Yeah, I think that's a really good question. And I think with regard to like primary care offices, I feel like there are a good number of people who are not as open to seeking mental health care and often will go to primary care and kind of talk about these things. And I think with regard to screening, I don't have a great answer for the best way to do that and to kind of prevent that pushback, but I think perhaps more training around these topics and being kind of willing to ask about them would be really important, and kind of being prepared to offer referrals or resources or recommendations for like further care.
Yeah, I think building up a good referral network for PCPs in this situation is really critical. I know from colleagues who do some work in perinatal clinics, the biggest piece is putting it on radars of physicians, like this is our service that we offer in this clinic to help, pregnant women who have experienced trauma, who might have specific, issues going to an OBGYN clinic around pregnancy. There's a lot of issues there. So I think, it's tough because it kind of depends location to location and what resources are around. But I think really building a strong referral network and just awareness of resources that are out there for physicians. Because I think, if we can make it as easy as possible for physicians to have information available to give to mothers to help them and do it in a way that may actually encourage them to seek out resources, anything to do around that seems to be a reasonable next step that could be feasible and at least practical.
And there's some discussion in the Q&A here about that some places in primary care, they do ACE screenings as well as depression and suicide screening and things like that. And that's absolutely right. I think it depends on the particular office, right? And whether they've had the training and the understanding of how to use and implement those tools, and then having the connection to where do you refer if these issues come up, right? Like all those things need to be coordinated for people to feel comfortable doing those screenings. Okay, there's another question here about, not sure if panelists will know this, but given the recommendations to increase screening across settings for both IPV and child abuse and neglect, do we have a sense of the best screening tools? Do we have any combined measures or tools. Anybody have any recommendations around that?
From my overlap in research in like early childhood mental health clinical work, I think that the probably most common screener that I see is that ACEs screener, where it gets at both potential risk of maltreatment and asks if a caregiver has experienced violence by an intimate partner. I've also seen in more integrated behavioral health type of settings with primary care, where they've also included kind of just dichotomous indicators that get at other social determinants of health that might shed light on some of those risk factors. But I think that those are predominantly setting specific and have been kind of developed in terms of like what works for them. So not that I know of that there's just kind of a consensus on a shared measure, but I welcome, Brianna and Jesse's feedback on that as well.
I mean, I think I can just chime in a little bit because I know a little bit about this area. I think Samantha's right. I don't think there's a consensus on a broadly used screen, but there are definitely short screeners available that are used in both OBGYN and pediatrics and other offices for IPV and child abuse and neglect. And I know there's the Child Health and Development Institute here in Connecticut has developed a screening, an ACE, a very short, like ACEs type screening for pediatrics for kids. So there's, that measure is available, and that there are others out there as well. But I think there hasn't been a coalescing of this is the tool that everyone should use. Okay. So there was a request to put the link for the special issue in the chat. That has happened. And then I think there was a question over here in the chat. I'm going to try to pull it over. Okay, this is for Jesse. I do not remember if you discussed a separate diagnosis of postpartum depression. Did you find that? Did you find correlation with ACEs and postpartum depression?
Yeah, I saw that question in the chat, so opened up the paper to look at our correlation table to see. So we did have assessments of depressive symptoms. So we administered the same screening questionnaire, the PHQ, at both time points. So we did have that assessment at 12 months. And I'll say we controlled for that in our analyses, and we did find that our specific analyses were specific to prenatal depression, not postpartum. For your question about was there a correlation, I checked, and there is, like a basic correlation between ACEs and depressive symptoms at 12 months as well.
Thank you. Okay, please continue to put your questions in the Q&A. So I have a question for Samantha. I was wondering what your thoughts were about why the fourth class was specific to early childhood. So when you showed your data, there were 4 classes in early childhood, and then the other 3 remained for the other developmental periods. And I just wondered what your thoughts were on that.
Yeah, we kind of, some of the findings too were just kind of a little, like it wasn't kind of this clear story across development and all of that. And so I think that we found that, well, I think that in some cases, children who were in homes where they're, well, okay, so let me back up. So I think because early childhood specifically kind of had a highlighted, so that fourth class was partner physical abuse and partner and child physical abuse and psychological aggression. And so our kind of thought process about why that might be is kind of to add to what Jesse's findings have found, that IPV risk is often heightened in that perinatal period. And so thinking then that might be heightened in the early childhood years when parents are adjusting to the stressors of parenting and all of that could have been unique for those younger kiddos. And then moving into middle childhood and adolescence, that maybe more intervention could have been in place at that point, where we kind of see less of those IPV effects impacting this sample. And then we saw consistently child maltreatment in this sample, but because it was a sample recruited from child welfare agencies in the US. And so that was kind of our thought process, that perinatal period and then early childhood is just kind of where we often see that increased risk in IPV. And so that potentially could have differentiated those children.
Thank you. Well, and it seems like your findings were that high family violence in early childhood, and that also, and in middle childhood, was associated with that high externalizing, but that really there was like the early developmental impact of that in particular.
Mm-hmm.
Yeah. So, suggesting that the developmental timing is really important for intervention, right?
Absolutely.
So we have a comment here that says communication with the primary care physician is needed for intervention. I don't know if anyone has thoughts on that. Seemed like a statement, not necessarily a question, but. Brianne, do you think there's anything, I'm sorry, Brianna, is there anything specific so the finding about psychological IPV only being associated with symptoms, and I think those of us working in the field of IPV, we know this, right? That sometimes the psychological violence actually causes the most harm. Are there things you think we can be doing to make that better known, or how can we help and the understanding? I mean, your data is important to that, but like, how do we get this message out into the field about, outside of those of us providing IPV intervention, how do we get that out into the field, that psychological violence is just as harmful, sometimes more harmful than the physical?
Yeah, I think with regards to psychological IPV, just more education and more awareness is needed kind of in the community. A lot of women don't realize that they're experiencing psychological IPV when in reality, the research shows that it's just as harmful as the more physical forms of IPV. So the research is there. I think just more education around that topic is really needed. And I think that can come from primary care physicians as well. So kind of tying that back in.
All right, so this is like a aerial view question for everybody. What, if you had all the money that you needed to do the next, study to follow on this current study that you presented in the journal, what would you want to do? What do you think are next big questions to answer?
Since I already mentioned it a few questions ago, I think, I'm really interested in that developmental timing piece and seeing how these trends evolve over time and how they're associated with different health risk behaviors. And so I think that, we know that investing in early intervention likely has the most influential impact, but just kind of better elucidating more specificity in terms of what risks are co-occurring, and then how is that impacting specific child outcomes, and then when is the best time to intervene. So maybe that wasn't like one research question and a whole.
I said you'd have all the money,
but yeah,
get all the money. You can answer lots. You can do lots of research. Anybody else?
Yeah, for me, I'd definitely be interested in kind of what we could do with this from an application or policy standpoint, with with our study, the PD study that this was drawn from, it does a great job of being able to look at more of these basic associations. So if in this case, found this interesting moderated mediation model, thinking through practically, does this speak to what home visiting could do? I know like the Home Visiting Research Collaborative has work on precision home visiting, how do we tailor our programs to serve specific individuals in certain situations the best? Like, are there pieces to that where we could integrate some of this to try to advance service provision for families? I agree with everything, in the comments and questions around integrating in primary care, integrating some of these things into screening and referral services, seeing if it does have an impact on families. So for me, my interest, I guess, would be really in looking at what are the actual applied implications of this, and are they meaningful? Are they sustainable? Those kinds of questions.
Anna, anything to add?
I echo what's already been said. And I think with regard to, building on my lab study, I wish that we would have had access to additional forms of child abuse and child maltreatment. So I think kind of a more holistic look at interpersonal trauma in that context, which I've seen today in presentations. So thank you.
Great, thank you. Okay, a couple more questions have come in. Are there screening tools specific to psychological IPV that folks are aware of?
So with regard to just really broad screening, I'm not too sure. I'm more familiar with the psychological maltreatment of women inventory, which is brief, it's 14 items. So I definitely think that could be really useful.
Psychological maltreatment of women?
Mm-hmm.
Yeah, and I will say in our study, because it was integrated into home visiting, a lot of the questionnaires we used were actually screeners. So that IPV assessment we used was the CTS short form, which does serve as a screening measure. And it does have, I think, 2 duplicated, 2 for the person, and then if their partner is doing it to them, related specifically to psychological IPV. So it's not perfect, but it is at a quick screener standpoint to see if it's happening.
Mm-hmm. Okay, and then does reporting to CPS or Child Protective Services on domestic violence exposure interfere with treatment? I'm not sure if that's anything that was part of any of your papers, or if any of you have comments from your experience.
Is that with respect to DV treatment, or I guess?
I'm not sure.
Okay. I know in the context of child welfare, if concerns of domestic violence are there, then often DV treatment becomes part of the treatment plan, at least just with the Colorado Departments of Human Services that I'm familiar with. With respect to DV treatment outcomes and how that might interfere, I'm not certain. I think maybe a question might come into mind of the extent to which that DV is influencing the child and places them at harm for it to become like reportable, and like those things would need to be weighed in, but I'm not sure if that question is with respect to DV treatment specifically.
Mm-hmm. Yeah, and I think, I can respond a little bit as someone who provides treatment. I think it can interfere with treatment if we have to make a Child Protective Services report, but I think there's a lot of ways that we can work with clients to explain mandated reporting. It only has to be reported to Child Protective Services. It also depends on your state and the requirements, but depending on the state, if a child is involved or there's a risk to a child as a result of the DV, then a report has to be made. And I think if you partner with the client and explain the mandated reporting, you make the report together, you help them understand what the process is going to be, you certainly can continue treatment with someone when you've had to make a report. All right, I think we have time for one more question. I'd like to see, actually, this is more of a comment, I think, but a good one that I really like, I'll say. It says, I like to see research that helps us understand the perpetrators of IPV, their ACEs, and prevention efforts that identify risk in non-traditional areas like unemployment offices. That's a fantastic suggestion, Sue. Thank you for putting it in the chat. And particularly, I like it because I do a lot of work and research on individuals who cause harm, usually dads. So that's an area I'm focusing on, and I really like this, thinking about access in unemployment offices. That's really a creative idea. All right, any last comments or things that the panelists, the authors would like to say before we close out this Q&A session? I know there's been a lot of chatter about the difficulty in reading the slides on the video. So people have asked if those are going to be made available. I assume that they are. Is that accurate? Or how would they be downloaded? I'm assuming that information will be put in the chat or something.
Hi, Carla, this is Rebecca. Yeah, we're working on that right now and hope to get a link to those for folks in just a moment. And I should also note that we are planning on posting the recording of this entire webinar on YouTube and through the AppSax YouTube channel.
Great, terrific. So everybody will have access to the slides and we'll be able to watch it again in another format, hopefully being able to see it better if that's what you'd prefer. So I think at this time we're going to close out this Q&A session. I want to thank the authors very much for responding to all those questions and for sharing your work with us and contributing to the special issue. It was really a pleasure for me to work with you all. And I think we're going to be taking a short break, but I'll turn it over to our facilitators at this time.
Thanks so much, Carla. Yeah, so we're going to take a 5-minute break, reconvening at 10:05. Everything's going to stay up and continue, but we're all just going to be muted and etc. So take a bio break, get a snack, etc. And we will have session 2 on the intimate partner violence, child maltreatment, and the impacts on children starting at 10:05 Pacific, which I think is 1:05 Eastern, if I did some good quick math there. Thanks. So again, big thanks to the first session. That was really great, and thanks so much, Carla, to facilitating. And we'll see everyone back in about 5 minutes.
Hello, and thank you for coming to this presentation of a paper I'm very excited to share with you all that was part of the special issue in Child Maltreatment. This project is titled Parenting Mediates Associations Between Intimate Partner Violence at Different Life Stages and Toddler Social Emotional Problems. Before I dive in, I'd like to thank my co-authors for their contributions and support on this project. To begin, we know that parenting behaviors and parenting beliefs about their parenting influence toddler social emotional development. Parenting can be influenced by contextual factors, including exposure to or experiences of intimate partner violence, or IPV, across the lifespan. IPV may be particularly important in understanding maladaptive parenting, which can pose as a risk for young children's social and emotional development. The impact of IPV experiences during childhood on later parenting is less well studied and was a focus of this project. In the present study, we hypothesized that maternal exposure to IPV during childhood and maternal experiences of IPV in adulthood would predict greater parent-reported social emotional difficulties in toddlers. It was expected that these associations would be mediated by self-reported parenting experiences and observed parenting behaviors. We expected that greater exposure to or experiences of IPV would predict more negative self-reported perceptions of parenting, as well as use of more negative observed parenting behaviors. These parenting variables were predicted to be related to poorer social emotional development among young children. Participants came from a longitudinal study examining mothers' experiences with pregnancy and parenting, and some demographic information can be seen on this slide. 120 mother, infant, toddler dyads participated. For this study, experiences of IPV were assessed at each wave. Recall to exposure to IPV between parents, measures of parenting, and measures of parent-reported toddler social emotional difficulties were measured at the 2-year postpartum visit. Overall, retention rates in the study were high. We had no significant demographic differences between those who remained in the study and those who did not. For this project, analyses were conducted using M+, using structural equation modeling to test hypothesized models. So first, a model assessing association among parent IPV variables, mother-reported parenting difficulties, and toddler social emotional problems was tested. There was no direct association between parent experiences of IPV in adulthood and toddler social emotional outcomes, but there was a significant indirect relationship. Greater experiences of IPV in adulthood predicted more mother-reported parenting problems, which in turn predicted greater toddler social emotional problems. Childhood exposure to IPV for mothers was not related to mother-reported parenting problems. A second model examined observed negative parenting behaviors as a mediator between IPV and toddler social emotional difficulties. Here, despite no direct relationship between childhood exposure to IPV and toddler social emotional problems, there was a significant indirect relationship through observed negative parenting behaviors. Specifically, childhood exposure to IPV was associated with more observations of negative parenting behavior, which in turn predicted more negative social emotional problems in toddlers. In this model, there was no association between mothers' experiences of IPV in adulthood and observed parenting behaviors or toddler social emotional development. So to summarize, results of this study reveal that both childhood exposure to and adult experiences of IPV are associated with mothers' reports of their toddler social emotional problems, although the pathway was notably different depending on when mothers were exposed to IPV. It may be that mothers who are currently experiencing violence are particularly aware of threats to the caregiving system. Mothers may experience distress and guilt about raising their child in the context of IPV, which may make them more likely to report subjective distress in the parenting role. Conversely, parents with greater exposure to IPV from childhood did not report elevated negative feelings as a caregiver, despite being observed as engaging in more problematic parenting behaviors when playing with their toddlers. For mothers whose exposure to IPV occurred during childhood, it's possible that they may be repeating what was modeled to them during childhood in their interactions with their own children, as evidenced by more hostile and conflictual interactions. With that, I'll say thank you again to my co-authors on this project, and I also would like to acknowledge my funding sources and to sincerely thank the research participants who allowed us into their homes to collect these data. And I look forward to any questions that you all may have. Thank you.
Hi everyone, my name is Doris Poot, and I'm happy to be presenting today on behalf of myself and my co-author, Dr. Christina Rodriguez, on research we completed at the University of Alabama at Birmingham. Our paper is entitled Spillover and Crossover Effects: Mothers and Fathers' Intimate Partner Violence, Parent-Child Aggression Risk, and Child Behavior Problems. Our study is grounded in family systems theory, which posits that subsystems of the family are interdependent and can impact one another through reciprocal causality or simultaneous mutual influence. We were interested in testing two hypotheses concerning how individuals and subsystems in the family affect one another. The first is the spillover hypothesis, which proposes that negative processes can be transmitted from one subsystem in the family to another, such as from the couple dyad to the parent-child dyad. The second is the crossover hypothesis, which proposes that emotions and behaviors can transfer across individuals within a subsystem, such as from mothers to fathers. So to test these principles, we examined potential bidirectional associations between intimate partner violence victimization, parent perceptions of child behavior problems, and parent-child aggression risk, which captures a larger spectrum of parent aggression behaviors towards children, including the likelihood that a parent will escalate their physical discipline and engage in physical abuse. Participants were first-time mothers and fathers drawn from the community who were enrolled in a prospective longitudinal study. So for this paper, parents were assessed at two waves. First, when their child was 18 months old, and again, when their child was 4 to 4.5 years old. Our sample was quite racially and socioeconomically diverse. Approximately half of mothers identified as a racial or ethnic minority, and nearly half reported an annual household income less than or equal to $40,000. Findings partially supported our hypotheses with evidence of some bidirectional spillover, unidirectional spillover, and limited crossover effects. Mothers and fathers who reported greater intimate partner violence victimization were more likely to later endorse greater parent-child aggression risk. In addition, the reverse was true for mothers. Mothers with greater parent-child aggression risk were more likely to later report greater intimate partner violence victimization. Together, this indicates bidirectionality. Results also indicated some other associations that were significant for mothers, but not for fathers. So for example, mothers' parent-child aggression risk predicted their subsequent reports of child behavior problems, meaning that mothers at higher risk of engaging in aggression towards their child at 18 months were more likely to report seeing problematic behaviors in their child at 4 years. Also, mothers' perceptions of child behavior problems at 18 months predicted mothers' later intimate partner violence victimization at 4 years. Finally, dyadic model analyses allowed us to identify some crossover effects between parents, with fathers' parent-child aggression risk predicting mothers' later reports of child behavior problems, and mothers' perceptions of child behavior problems predicting fathers' reports of child behavior problems. In other words, for both mothers and fathers, their perceptions of their child were related to and possibly affected by their partner's attitudes or perceptions of the child. So overall, current findings suggest that mothers rather than fathers may exhibit stronger spillover effects, which means that for mothers, higher parent-child aggression risk may signal an increased risk for subsequent intimate partner violence victimization and vice versa. This will, of course, have important clinical implications, as it suggests that parents seeking treatment for couple conflict might benefit from screening of their parenting or physical discipline behaviors, and that families seeking treatment for parenting difficulties might also benefit from screening of couple conflict and prevention of intimate partner violence. Thank you for listening, and I'm happy to take questions during our live Q&A hour.
Hello. My name is Vivian Lyons, and I'm a postdoctoral scholar with the University of Michigan as part of the FACTS National Consortium, the Firearm Safety Amongst Children and Teens National Consortium. And I'm here today to talk with you about risk factors for child death during an intimate partner homicide, a case control and study. So the motivation for the study truly began when my colleagues and I conducted a study using the National Violent Death Reporting System, which I'll briefly discuss again in a moment, to examine the role of firearms and protective orders in intimate partner homicides. And in that first study pictured here, we found 8% of the victims of intimate partner homicide were corollary victims. That is, that they were not intimate partners of the perpetrator. And half were a child of the perpetrator, half of those corollary victims. We also saw that 57% of the incidents were completed with a firearm. So we started to wonder if there was a way we could really examine risk factors of child death in intimate partner homicide and quantify additional risk factors, such as when a firearm was used. And the challenge being that many NVDRS papers suffer from some form of selection bias. That is, they often only include individuals who died by other means, rather than comparing incident characteristics to situations where individuals survived. So this substantive question and methodologic challenge really led to two papers. The first, a methods paper where we discussed the reasons for these biases and potential for misclassification, as well as proposed methods to counteract them. And the second is the paper I'll be discussing in more depth, where we attempt to answer the question using some of the new methodologic approaches we proposed in the injury prevention paper to prevent this form of selection bias. So our question really was, what are risk factors for child death in an intimate partner homicide? We use the National Violent Death Reporting System, which collects data from 4 major sources about the same incident. So death certificates, coroner medical examiner reports, and law enforcement reports, as well as crime lab reports, and it links together the data that occurred in the same incident into a usable anonymized database. So information on the perpetrator, the victims, all linked together at the incident level. The data is synthesized at the state level and then de-identified and uploaded to be collected by the CDC. It includes data on the relationship between the victim and the perpetrator, life stressors, mental health status, existing conditions, other crimes, as well as circumstances unique to particular forms of violence. And one of the big benefits of NVDRS is that it has both narrative data and coded fields. So it can include some information on other family members, individuals at the incident, or the perpetrator. And some of these constructs are captured both in the narrative data and coded fields, and some are captured in just a single place. So to identify cases and controls, we defined cases as intimate partner homicide with 1 or more child corollary victim. And we defined controls as an intimate partner homicide without any child corollary victims, but where a child was physically present. We used data from NVDRS from 2003 to 2017. And we used the following process to confirm case and control eligibility and abstract data. So first we used the coder abstracted variables. This is NVDRS coder variables to identify all intimate partner homicides. We then used age and number of victims in the incident to identify potential cases. We used JUMP software to search narratives of potential controls for child-related terms to identify potential controls. And then we had manual review of all narratives for potential cases and controls to confirm eligibility and abstract data elements. We used descriptive statistics and logistic regression with Holmes step-down method to account for multiple comparisons. And the risk factors we examined were really drawn from the literature as risk factors for intimate partner homicide generally. We wanted to see what those, if those were also risk factors for child death in an intimate partner homicide. So we found the majority of intimate partner homicide adult victims were female and current intimate partners of the perpetrator at the time of the incident. Of the 365 corollary victims who were not intimate partners of the perpetrator, 88.8% were children. Perpetrators of incidents with child death were more often white, and those incidents more often ended in homicide-suicide. Overall, the most common location of intimate partner homicide was the victim's home, and firearms were the most frequent mechanism used. Children were rarely the first person killed in case incidents. It happened only 8.5% of the time. And children in control incidents were older on average than children in case incidents. It was uncommon for a child to be present and injured, but not killed. 7.6% overall. And then when we look specifically at the pre-specified risk factors for child death, we see that history of suicidal behavior, rape, non-biologic child of the perpetrator in the home, and job stressors all increase the risk of child death, while separation of the victim and the perpetrator prior to the incident decreased risk. So I think it's important to remember for all of these, both cases and control incidents, that they all included an intimate partner homicide. However, risk factors that additionally increase child death during an intimate partner homicide, such as history of suicidal behavior of the perpetrator, rape, and non-biologic child of the perpetrator in the home, as well as job stressors, I think can be used in screening and risk assessment. The separation of the intimate partner and perpetrator decreased risk of child death. And I think for me, initially, that was a little bit counterintuitive, because we know that separation of the intimate partner and perpetrator is one of the biggest risk factors for both intimate partner homicide and severe intimate partner violence. I think after thinking about it for a bit, I think that this is likely due to the, if there is that additional separation, the intimate partner victim may be in a new home, the partner may not have, the perpetrator may not have access or keys, so the incident may take place right outside rather than inside. The children may be inside, or there may be hiding places that the perpetrator doesn't know about. I think that sort of helped me understand how those two findings could be true and counterintuitive initially. So I'd love to take questions and hear your thoughts. Thank you so much.
Okay, good morning, good afternoon, everyone, depending on where you are. My name's Dan Whitaker. I was one of the co-editors of the special issue, along with Damien and Carla. Thanks to our presenters today for their excellent presentations, and it's now time to take questions. I'm looking at my screen trying to figure out where they're going to be when they show up. I don't see any in the open Q&A. I'll start with one, and I think this is relevant to all the presenters. But I'm wondering, particularly the first two papers, there's an interplay between experiences of IPV and parenting behaviors, and I'm wondering how we might think about parenting interventions, how they might be adjusted or adapted based on the presence of either current IPV or past IPV. So any thoughts on that?
Sure, I can dive in. I think it's a good question. In the paper that I presented, I was really surprised. So I'm a clinician who primarily works with parents and young children, and I was surprised that like concurrent adult experiences of IPV were predictive of how the parent perceived parenting, how stressed they were, how good of a job they thought they were doing, but it didn't necessarily predict negative parenting that we were observing and coding. And we were coding those interactions really blind to the IPV experiences of the participants. And so I think that parenting interventions need to be sensitive to addressing specific behaviors that parents may engage in that can lead to worse developmental outcomes for children. But I also think interventions need to be really tailored toward understanding a parent's conceptualization, their working model of their parenting, and to provide support and perhaps to utilize things like video review to be able to watch an interaction and point out, here are the things that we're seeing that we see as strengths, as moments where you're connecting and engaging in these really high quality behaviors, but to also hear the parents' perspective so we can identify misperceptions, misunderstandings, and also understand how their past experiences are implicating not just how they're parenting, but how they view their parenting as well, which I think is pretty important.
Yeah, really good thoughts. I mean, it really struck me, Jessica, in your paper that past IPV and current IPV had sort of a different relationship with parenting, and it made me kind of think about like, okay, what are the proximal drivers of that in terms of, you know, the parent's current emotional state or cognitions about themselves and so on. Do any of our other panelists have anything to add to that on that question? Okay, I see. Go ahead.
I was gonna say, like, I think the paper that Doris presented really sort of speaks to the idea that there is such substantive overlap between some parenting, even when it isn't at the same time point, and it being affected, that if we're going to look at parenting interventions, we do need to pause and ask ourselves what's happening to the parent in their own relationship in a way that we don't often think of. We forget to think about the family more broadly, and we probably need to do that a lot more systematically than we are. To Doris's point, her takeaway message of that we maybe need to be doing a little bit more screening than we are doing when we're doing parenting interventions that seem to be focused on the child, and we forget to pay attention to what's happening at the couple level.
Yeah, that's a great point, especially because I think, you know, you can certainly think of instances and find them in literature where, you know, the couple or the partner is either a positive or a negative influence. I mean, here we're talking about partner violence, so it's obviously a negative, but you know, there's literature on co-parenting that would suggest it could be a positive as well. And so, you know, that coupled with the fact that much of the criticism of the parenting literature is that it's really about moms and individuals rather than the couples, I think would be really interesting to see interventions or even more research like you all have done take into account what does this parental relationship look like and how is that affecting parenting in good or bad ways. Okay, we've got a couple of questions now in the chat box. One is I think this is probably for Vivian. Does using the ASQ with parents help identify increased risk of child homicide?
That's a great question, and I don't know. When we were using the NVDRS, we didn't have access to that, so I'm not sure. I'm not sure, but I'd love my other panelists' thoughts, because I do think it's a really important way to get at the dynamics in the home and in the relationship and in the family. And so I think, yeah, I could imagine that it could be useful, but in the data that we had, we weren't able to look at that.
Anybody else want to weigh in on that?
Is the ASQ, is that are you referring to, like, could you just specify which? I'm thinking with clinically and research, so a couple different ASQs are coming to mind.
Yeah, I'm not sure which one they were referring to. We don't, I mean, in NVDRS, we don't have access to any of the ASQ screeners. So.
ASQ is for suicide risk, is what the question asker has clarified.
Oh, funny. I thought you were referring to the ages and stages questionnaires. No, so with NVDRS, the data, right, comes from medical examiners and law enforcement reports. There's no interviews with the survivors of an incident that are directly entered into NVDRS. So it would only be information that's captured by law enforcement and then put in the law enforcement report, transferred to the state level NVDRS abstractor, who then makes the determination that that information is germane enough to the incident to be entered into the national de-identified data set. And so there's a lot of unless there's the cases that I've seen where there is some sort of indication for suicide type screening, I think has been in cases where there was a suicide and the focus of the incident wasn't intimate partner homicide. So one of these incidents might have an indication that the perpetrator had, mentioned thoughts of suicide, suicidal ideation, or had been diagnosed with depression, or had a prior suicide attempt, but the level of specificity around suicide screening, I think is I haven't seen before in NVDRS.
Mm-hmm. Yeah, thanks for that. Vivian, I'll ask one other question. There are a few others in the chat, but since I remembered and you're talking, it was really about your paper. And I wondered if you had any thoughts. I mean, the paper was really interesting in that it examined the most extreme outcome or most extreme negative outcome of partner violence, which is death. And I wondered if you had any thoughts about looking at the same kind of analysis with a sort of a maybe child injury and where you might have larger samples and obviously the literature shows it's bad for kids to be around partner violence, whether they're witnessing it or injured. But it struck me that if there was a data set where you could untangle whether kids are injured during or harmed physically during a partner violence episode, that might be an interesting sort of follow-up to your paper. Do you have any ideas about that?
Yeah, I mean, I think it's an incredibly important point, and something that my colleagues and I talk often about is trying to find data sets that we can link that can really allow us to look at that. I think often when you're relying on medical record data, you don't have access to the sorts of risk factors that we were interested in looking at, both in this study and broadly, or family dynamics. Usually you're limited to like the insurance status or zip code, those sorts of general demographic information. But it doesn't really tell you the story of what's actually going on in the home. I think, there's been some great work that's linked medical records and crime data or court record data, but that still doesn't tell you about perpetrator job stressors. It doesn't tell you about rape that hasn't been reported to the police or where there hasn't been charges filed. So yes, incredibly important question. If you know of a data set that would let us look at that, let me know. But no, I think it's an open question still. And I mean, to your point, right, there's so many child injuries, but there's also so many harms to children that are not physical injuries. And they're finding data sets that capture those in sort of a census, as well as have all these other factors included. I haven't come across on a big scale yet, unfortunately.
Yeah, and that was really sort of where my question was coming from, trying to just dig a little deeper into what those harms are and why they might be occurring. If you could sort of segment out kids who are actually getting physically injured from those who are witnessing versus, they're in the presence in the household, but maybe not witnessing, that could be pretty interesting.
Yeah, I think, sorry, I'll just say one more thing, which is I think the way I see to do that is through like more intensive data collection methodologies with a smaller sample first, because I think there's so much of abuse patterns and so much of child maltreatment, I think doesn't all rise up to one of our even CPS data or one of these other larger data sets. And so getting at the broad spectrum of harms that children experience directly or exposed to in the home, I think is really going to require a couple very intensive, daily diaries with a cohort of people who are willing to share that sorts of methodologies. So yeah, I think that's a direction I would love to see work done in.
Great. Couple other questions. One is, and I'm not sure exactly who this is directed to, but do you place parental, I think it's a more general question, do you place parental IPV in a child's charts problem list? In other words, I think what the question is getting at in a typical clinical environment is parental IPV captured in a way that somebody working with the child might know about?
I can say what I do. So I work as a clinical psychologist, primarily working with kids age 0 to 6, lots of whom have been exposed to intimate partner violence or some other form of child maltreatment, neglect. And often those children, I provide a diagnosis of PTSD or trauma, other stressor disorder. And in my conceptualization, I'm very clear to link how I understand how exposure to IPV in the home has cascaded into a DSM diagnosis. So it's captured there. Vivian, after listening to your talk, I think I'll be more thoughtful about thinking about the systems of care and sort of thinking about touch points kids experience and thinking about identifying those risk factors in a broader sense. Sort of given the outcome that you were looking at, I think it's important to think about it in a larger system of care way as well, not expecting every provider to drill down into my therapy notes.
Here's a question. I think this is targeted to Vivian. When IPV results in death, was there any pattern as to the age of the children? Or was that captured even?
Yeah, so we saw, I think it's in the table 1 in the paper, the children in case incidents were often younger, which I think speaks to their ability, like a child's like bodily agency and ability to move away in situations with danger. So in the incidents where children were present and not killed, they were often like young adult teen ages.
Gotcha. And another one, a follow-up. It's a little long, so I'm gonna hopefully read it so you can understand it. To clarify, in the last paper, perpetrator child separation was related to the child's safety and not the parent victim safety, correct?
Correct. Yeah. So every incident that we included was an intimate partner homicide where the either at the time of the incident, current or former intimate partner of the perpetrator was killed. So it's definitely still this doesn't contradict the literature where we know that separation really is a dramatic risk factor for both severe violence and intimate partner homicide. This is saying above and beyond that risk that it poses to the intimate partner, it looks like separation decreases the risk of additional child death in the case of an intimate partner homicide.
And then a follow-up to that, does the child being separated from the perpetrator have a negative impact on the parent victim? For example, one can imagine that the perpetrator, in their anger that the child was removed, might take it out on the parent who remains in the home. Well, what's interesting before you answer that is, I wondered the opposite, that I wondered if having a child in the home when there's an incident might in some way be protective of the parent, meaning it might diffuse some of the perpetrator's willingness to be violent. I mean, obviously not in many cases, but so obviously you could see it going either way. I'm wondering, what are your thoughts on that?
Yeah, it's a great question. And to your point, Dan, I mean, we weren't able to look at the role of a child in an intimate partner violence incident where they may have some sort of mediating effect on the escalation of violence. But to the question, I think I think the question is referring to child separation from the perpetrator, but it wasn't child separation, it was partner separation. We didn't measure CPS removal or sending the child to live with another family member. It's really the partner separation and and the child living with the partner who separated.
Gotcha. Okay. I think we've gone through most of the questions in the chat box. Are there other questions? I guess I'll just throw out a broad one here, and that is, it's been an area of controversy in the field of partner violence that typically people talk about perpetrators and victims in partner violence, but when you dig down into the data, there's often multiple perpetrators and multiple victims. And this view of dyadic partner violence, again, it's been controversial because of the history of partner violence, and because we know women are much more likely to be injured and killed than men. But I wonder how much of that is relevant, particularly around partner violence associations with propensity for maltreatment. And so, this sort of idea of a general tendency to aggress against, whether it's a partner or a child, could sort of tie those concepts together. It's just something I've thought about over the years, and thinking about kind of the relationship between the two forms of violence that are obviously closely related in reality, but often not studied together. I don't know if that made sense.
Yeah, so Christine and I have actually worked on a paper on this topic of reciprocal versus non-reciprocal intimate partner violence, and kind of acknowledging that reciprocal or bidirectional IPV is actually the most prevalent type. And this is a whole separate paper, not kind of addressed in our child maltreatment paper, but I think that would definitely be interesting to consider, right? So obviously there are gender differences in, in the intensity, frequency, duration of IPV. When it's reciprocal or non-reciprocal, there can be differences in motives. There can also be differences in like the risk factors, right? Personal adjustment, psychosocial resources, attitudes towards gender roles even, which would be really interesting to incorporate with our child maltreatment data. And I think that would be a really exciting future direction of research.
Yeah, I agree. And I think when we think about child outcomes, it would be interesting to try to understand. I think it's not controversial or hard to imagine that bidirectional reciprocal violence would be worse for the child than one way. More is usually worse. But I sort of wonder if that might have a special impact, because I don't know, again, as we think about partner violence, the typical way we think about it is the dad or the boyfriend being the primary perpetrator and the mom being the primary caretaker. And so, if mom is also involved in perpetrating violence, then what does that really mean for the child? It might mean something even worse than it would otherwise. And I know there's some older data that shows that mother's perpetration of violence is especially bad for kids. And again, my assumption is that's because the mothers are typically the primary attachment, particularly where there's single parent households.
I would concur that it remains an amazingly controversial topic to discuss reciprocal violence, even though it is the most common form, because somehow people think that equates the severity, and that's not really the discussion. It's about whether or not you have an environment that fosters violence. And so, to your point, I do think that you would expect that there would be worse outcomes for children and worse parenting on the part of children if you have a family violence as the context for parenting.
Right.
If everybody's hitting everybody else, this cannot be a good thing.
We have, let's see, I got a chat. So I have a question in a chat. So the question is whether there are any studies that included data regarding LGBTQ parenting situations. Do we know anything about your samples, whether those folks were included?
So in the study I presented, all of the participants identified as straight and were women with male partners. So I agree, it's an area of needed research for sure.
Yeah, they were included in our study, but not called out specifically. So because we weren't specifically examining LGBTQ family dynamics, but we didn't exclude anyone. So the census of intimate partner homicides with children, and then the controls.
I think similar to Jessica, our study didn't explicitly include LGBTQ parents, but I think that would be incredibly important to study and really interesting, right? With kind of gender role attitudes, non-traditional sort of family structures. And I think, especially in society today, right, we're seeing all sorts of new kind of family structures that maybe we haven't considered in the past, step families, blended families. And so kind of those structures are all really interesting and can definitely impact like parenting, family dynamics, all worth considering.
Agreed. We have a more of a comment than a question to mention that in many states there are extreme risk protection laws that can be utilized to protect vulnerable victims of family violence. I think the question, the attendee just wanted to point that out to everyone, so we were all aware. Unless any of the panelists see that as relevant. Another comment that maybe we could think about is there's also evidence that use of violence increases victimization. So a context where perhaps mom's violence towards a partner may escalate the violence overall. This could contribute to the impacts on children in terms of overall environment, fear, et cetera. We need to better measure the dynamics that go beyond behavior to get at some of what Doris mentioned, impact motivation. And this is a perennial problem for sure. Completely agree that I think for years in the IPV world we've been talking about these lousy behavioral measures that we have, and of course we keep using them for lack of something better. It's hard to capture the full context around a violent episode, and I don't. This hasn't been my main area of focus for a while, but when it was, I didn't know of any studies that really got into the full context of violent episodes. And as Christina was saying, that when you look at studies of reporting violence, that the bidirectional violence is the most common. It would sure be interesting to hear from each of the perpetrators in those instances about how they perceive the actual incident or incidences of violence unfolding in terms of what happened and so on. And I don't think there's really good data on that. This notion of violence escalating to the point of, conflict escalating to the point of violence, I think is important. But to my knowledge, I had not seen much data suggesting that that actually happens. I think we think it happens, but in terms of qualitative studies or whatever, that would show that.
I think we also.
I'm sorry.
Go for it, Christina.
I was gonna say, in fact, one of the nuances that Doris had looked at in that reciprocal paper was who you even ask, right? Like who's the source of the information about whether or not there's violence happening, and how the findings differed if we looked at it from just self-report versus whether or not you actually asked both members of the couple, and how rarely people do that. They just ask one person to report, and you may not get the full perspective of how much perpetration and how much victimization is really happening. So we're woefully behind on how to do this well.
Really, what are, for me, I think it's also important, what are the proximal triggers? There are studies that ask people about their motivations, but I think we also know that asking people about their motivations isn't always the best way to assess their motivations. People aren't always good judges of their own motivations. And so, I think if we could get at behavioral triggers, that might allow us to make inference about motivations.
I also think it's difficult in the context of IPV. Just thinking about the coercion and the manipulation in a way someone might blame someone, like, I hit you because you did XYZ. Even asking both partners can lead to, and maybe just reveal some of the biases that people have because of these experiences, and not seeing the situation without sort of through that lens of blaming themselves. I also think an important sort of discussion around this sort of dyadic IPV is sort of thinking about the experience of a child and that family, and sort of not having a predictable caregiver that they can turn to when they're around a scary parent, or when one parent is sort of engaging in scary behavior. I think the literature on atypical or disrupted parenting using measures like the ambiance or FR coding system for parenting is really important at sort of capturing parenting behavior that leads kids to feeling confused or disoriented. And certainly being parented in the context of IPV can create that. And my hypothesis would be the dyadic IPV would exacerbate that without having a parent you feel comfortable turning to or looking to when you feel afraid in your own home.
Yeah, for sure, because now you have two parents being violent. And again, one may be in response to the other, but one other question came in. So the question is this: we saw how parenting behavior is influenced by the childhood experiences of parents. Do you think it would be helpful if we can also take culture into account when analyzing cases of IPV and child maltreatment, especially in places where we have more gender biased stereotypes for mothers? What are thoughts on that?
Yeah, I mean, I think that's hugely important, right? The differences in culture, the cultural norms, and what people may have seen as normalized conflict within, other cultures that that may not make sense in our culture, or may cause harm to children. I think, it's hugely important to think about, and I think there's some work that's been done, but definitely a lot more work that could be done to think about how to support, especially, people who are immigrating, refugees, folks who are coming from different cultures and exposed to different norms here, or their children are exposed to different norms here, or to have different behavioral peer behaviors that they may be engaging with. And I know that can sometimes cause some conflict, not necessarily maltreatment or violence, but can cause conflict in the home when there's different parental norms. So hugely important.
Yeah, I want to echo what Vivian said about the importance of considering cultural context, and also kind of point out, right, that cultures and cultural groups have a lot of variability within groups, right? So even individuals in the same cultural group may have very different beliefs about parenting, or different levels of acculturation. And so that's definitely important to consider, both between group and within group variability, not to treat culture as deterministic.
Good thought. We have about 1 minute left before we break and take on the next and go to the next set. Is there a final question or comments from any of our panelists? Oh, wait a minute. Sorry, I think I'm. So we have a comment in the Q&A. So I think that the comment is, or the comment is a fuller one of one before, just to mention that many states there are risk protection laws that can be utilized to protect vulnerable victims of family violence. And the presence of firearms in the home definitely increases the likelihood of injury and homicide. Yeah, I think that's clearly the case. Any final comments from our panelists on that or anything?
I will say that the other area of that remains to be seems controversial is this idea that children might elicit behavior on the part of their parents. And that we tend to be very reluctant and reticent to say that somehow some children might be more challenging, and because they're more challenging, again, could have been because of the experiences that they had preceding, but that now a child who's now more challenging presents a greater difficulty with regard to their parenting, and that parenting can then spill over to affect their couple relationship. And so again, this more holistic way of thinking and not getting too caught up in this idea of who's to blame, which is, I think, our tendency to somehow think like if we acknowledge that everybody's like a part of a family, somehow someone must be to blame. Like that's, if we could move away from that, that'd be super helpful.
Yeah, great thought, Christina, in closing. Well, I think we're out of time, so I just want to thank Jessica, Doris, and Vivian for their presentations, and thank them and their co-authors for contributing to the special issue. And it was a real pleasure to be here with you. And I think we'll take a break, and I'll turn it back to the moderator to keep us going.
Thanks so much, Dan. And just want to echo again, thanks so much to Jessica, Vivian, Doris, and Christina for a great session. We are going to take another 5-minute break. So coming back at 11, and we'll start the final session, which is intimate partner violence, child maltreatment, and system responses. So see folks back here at 11 Pacific, 2 o'clock Eastern. Thanks. Hi, my name is Rebecca Reeby, and I am an assistant professor at the University of Southern California School of Social Work, and I'm here to present our paper, The Co-Reporting of Intimate Partner Violence and Child Maltreatment, the Likelihood of Investigation Outcomes. And I'd like to acknowledge my co-authors on this paper, Andy Lane Eastman from USC, Avanti Adiha from the University of Washington, Reagan Faust, also from USC, and Emily Putnam Hornstein from the University of North Carolina at Chapel Hill. Second, I'd also like to thank our sponsors for this work. Specifically, the Blue Shield Foundation of California sponsored this, provided funding for this work, and acknowledge our partners, the California Child Welfare Indicators Project, QUIP, and the California Department of Social Services, which allowed us the access to the data for the analysis. But want to acknowledge that the opinions and analysis is our own work. So a little bit of background, but I'm going to keep this very brief, that, intimate partner violence is a common occurrence in the United States. And it's estimated that 8 to 15 million children are exposed to IPV annually. One of the responses to this type of family violence is Child Protective Services. And so we wanted to kind of look at, what cases are, when cases with IPV are reported to CPS, what happens. And it wanted to note that specifically in California, that IPV or domestic violence is usually captured under the category of emotional abuse as the maltreatment type. So our study had 4 primary research questions. First, we were interested if there were differences in regards to hotline screening decisions between CPS reports with and without IPV concerns. Second, we wanted to know if among cases or reports that were screened in for investigation, were there differences by the presence of the IPV allegation? Third, what was the frequency that IPV was co-reported with physical abuse and neglect allegations? And finally, what is the likelihood of investigation outcomes based on allegations of IPV? So the data for this study included all California CPS reports between 2010 and 2014 for children under the age of 5 with no previous placements. An IPV allegation was indicated using the structured decision-making assessment tool that hotline workers use, and this was just a binary indicator of yes or no. Our analysis included 369,766 unique report child dyads, of which 305,000 were screened in for investigation. So what did we find? So in regards to our first question regarding screening differences by the presence of an IPV allegation, we found that reports with IPV allegations were much less likely to be screened out. While about 20% of reports without IPV allegations were screened out, just 3.2% with IPV allegations were screened out. While we did not find much difference regarding immediate or emergent response screening decisions, the lack of screenouts means that almost all CPS cases with an IPV allegation were screened in for investigation. Regarding screened-in reports, we found that about half of reports with IPV allegations came from law enforcement, where just 18% of reports without IPV allegations came from law enforcement. Regarding the co-reporting of maltreatment allegations, we found that allegations of IPV and neglect occurred in 8.5% of screened-in reports. Allegations of IPV with physical abuse occurred in just over 4% of screened-in reports, and that 7.2% of screened-in reports had allegations of IPV without a physical abuse or neglect allegation. And we can see here that about 20% of the screened-in reports had IPV allegation, but about 80% did not. So for our fourth question, we use multinomial logistic regression for the possible outcomes. We then use the results from the multinomial logistic regression to plot the predicted probabilities of each outcome. And this is the results. So each of the different colors is a different set of maltreatment allegations. And the different columns are each of the possible investigation outcomes. So we found that reports with allegations of IPV without physical abuse or neglect had the highest predicted probabilities of resulting in inconclusive findings at 38%, as shown in the box in the far left. Similarly, when we look at the middle box for the probability of substantiated without a case open, we found that reports with IPV and physical abuse or neglect had the highest probability of having allegations substantiated. Or in other words, a case continued to be open beyond the investigation. In regards to placement, in the far right box, few reports with allegation of IPV resulted in placement, with a high of 11.1% for IPV and neglect, then 9% of IPV and physical abuse, and just 3% for those with IPV without physical abuse or neglect allegations. So we see that in sum that placement was a fairly rare outcome for these reports with IPV. So just to summarize our findings, we found that about 21% of CPS reports included an IPV allegation, a number that was higher than traditional coding schemes in California that categorize IPV as emotional abuse. If we looked at just emotional abuse, we would not see the number that high. About half of reports with concerns of IPV came from law enforcement, which highlights how these cases likely require interagency collaborations. And we found that out-of-home placement was not a frequent outcome, and that the high rate of cases closing, even with a substantiation of allegations, likely indicates that services are offered outside of the child protection system. We really want to thank everyone for coming to this convening. And if you have any questions, feel free to reach out to me, and I'd be happy to answer any questions that you may have. Thanks.
I'm Elizabeth Armstrong, and I'll be sharing key findings from my paper with Emily Bosk, Contradictions and Their Consequences, How Competing Policy Mandates Facilitate Use of a Punitive Framework in Domestic Violence Child Maltreatment Cases. Since the early 2000s, states have increasingly shifted from a punitive approach to caregiver domestic violence, which often resulted in substantiation of domestic violence victims for failure to protect, and towards a supportive framework which centers accountability on perpetrators. Despite this, large-scale studies using administrative records show substantiation is still a common outcome in cases involving caregiver domestic violence. Our research was motivated by this puzzle. Why, despite an overall shift towards a more supportive policy framework, do domestic violence child maltreatment cases continue to result in punitive consequences for victims? To answer this question, we used a grounded theory approach to investigate child welfare worker decision-making. We were especially interested in the role of the structured decision-making risk assessment, an actuarial-based risk assessment tool that categorizes cases into low, moderate, high, or intensive risk of future child harm. Our data included semi-structured interviews with a purposive sample of 34 frontline child welfare workers, all publicly available primary source documents about the structured decision-making model, and the Policy Services Manual, Practice Model Manual, and Field Guide for Investigators from Midwest State, where we collected our data. In using the Safe and Together model for domestic violence child maltreatment cases, Midwest State exemplifies the supportive framework. It's also an ideal case for studying the role of actuarial-based risk assessment because risk categories are tightly linked to service eligibility. In Midwest State, specialized investigative procedures are meant to apply to domestic violence cases. Workers are supposed to substantiate only with evidence that a child was or could have been harmed because of domestic violence and are to use a separate risk assessment tool. This separate risk assessment focuses on the perpetrator and in content overlaps considerably with domestic violence specific risk assessment tools like the danger assessment. Interventions in domestic violence cases are meant to strengthen the adult victim's ongoing efforts to keep themselves and their children safe, regardless of their relationship status with the perpetrator. Given Midwest State's implementation of a supportive policy framework, we expected victim substantiation to be rare. And although most workers did describe efforts to limit consequences for victims, punitive outcomes were common. Adult victims were substantiated in 4 out of 10 cases overall and 6 out of 10 substantiated cases. Workers struggled to operationalize concepts like exposure and harm, and in seeking guidance, drew on a variety of policies. These often contradicted the Safe and Together model. For example, the definition of threatened harm lists residing in a household where domestic violence has occurred as a potential threat to child safety. Risk assessment procedures also embedded the punitive approach. When asked about risk assessment, all workers described using the structured decision-making tool and none referenced the separate domestic violence specific assessment. The structured decision-making risk assessment treats domestic violence as a risk regardless of recency, severity, or level of child exposure. Most questions focus on the primary caregiver, a role workers typically assigned to the adult victim, despite the expectation they focus on the perpetrator. Applied to domestic violence cases, the structured decision-making risk assessment sometimes resulted in an underestimation of risk through its focus on the primary caregiver. In cases where the perpetrator was centered, it produced a single score that was applied to both victim and perpetrator. To limit consequences for adult victims, workers could avoid substantiating the case at all, which meant the family would receive no supportive services. Alternately, they could use informal interventions to reduce risks before they completed the risk assessment. Informal interventions usually involved pressuring the adult victim to sever ties with the perpetrator. When they were no longer in the same household, workers could complete separate risk assessments for both parties, yielding a caregiver-specific risk score. When workers convinced victims to end the relationship, however, perpetrators often ended up ineligible for services because receipt of services required a child reside in the household. When the victim did not end the relationship, workers assumed they did not take the situation seriously or that they were unable to put their child's interest first, ultimately resulting in a higher risk score for the victim. Overall, 1/3 of the cases described to us were categorized as high risk, and in 9 of those 11 cases, both victim and perpetrator were substantiated. The remaining 2/3 of cases were categorized as moderate risk, and 1/4 of those involved dual substantiation as well. In moderate risk cases, families were referred to services in the community with no follow-up or ongoing support from child welfare. These families were often referred back later for the same or similar issues. Each new referral reduced worker sympathy for the adult victim, resulted in a higher risk score, and increased the likelihood of punitive consequences for the victim. Our paper demonstrates the consequences of competing policy mandates. The Safe and Together model and structured decision-making were developed separately and adopted separately, both with the best of intentions. As workers investigate cases and make decisions about risk, substantiation, and services, these policies collide with unintended consequences that fall heavily on already vulnerable families. Full implementation of the supportive framework requires identifying points of conflict with other policies and procedures and resolving them in favor of support for adult victims and children. Our findings suggest the need to re-examine definitions of neglect and threatened harm, procedures governing risk assessment, and potentially risk assessment tools themselves. We found that workers relied on structured decision-making risk assessment because its use was required. DV supportive risk assessment procedures must be backed by parallel accountability mechanisms if we expect workers to use them. The structured decision-making risk assessment embeds a punitive approach to domestic violence. In focusing on the primary caregiver as the primary source of risk, dominant risk assessment procedures shift the focus of attention and intervention from the perpetrator to the victim. Sole reliance on this risk assessment may also lead workers to discount known risks of reassault or lethal assault that are included in domestic violence specific risk assessments. Ultimately, supporting adult victims of domestic violence and their children in the context of child welfare requires moving away from a one-size-fits-all approach to risk and towards integration of the best available knowledge across practice areas. A renewed commitment to differential response in substantiated low and moderate risk domestic violence cases, and identification and mitigation of contradictions between policies to ensure supportive outcomes for all families. I look forward to talking with you more about our paper at the virtual conference in a few weeks. Thanks for listening.
Hello and greetings to all of you. I'm Brian Victor, and I'm pleased to have this opportunity to provide a brief overview of our paper today. We had two overarching aims of this study. The first was to describe the range of policy approaches used by state-administered child welfare systems in the United States to guide workers in substantiating childhood exposure to domestic violence as a form of maltreatment. And the second aim was to assess the alignment of a given state's policy approach with a set of quality policy indicators that we established based on our findings. Our motivation for this study really came from thinking about the roughly 20 years of research, scholarship, legal cases, and advocacy in this area that have collectively encouraged child welfare systems to not automatically classify exposure to domestic violence as maltreatment, and to move away from a failure to protect framework. And that framework really views adult survivors of domestic violence as placing their children at risk, and to instead shift to a framework where we give our attention to caregivers who perpetrate domestic violence and focus on holding those individuals responsible for the harm that they cause. To complete the study, we acquired the CPS policy manuals from all 41 state-administered child welfare systems, and then we converted those manuals to machine-readable documents that allowed us to identify relevant passages. We then completed deductive and inductive coding to describe the range of policy approaches in this area. We ended up coding for these four categories: maltreatment threshold, maltreatment types linked to CEDV, whether workers were told to identify a primary aggressor, and types of protections against substantiating survivors for childhood exposure to domestic violence solely on the basis of their own victimization. The most commonly used threshold for substantiating exposure to domestic violence, which was present in just over 70% of manuals, was a harm or threat of harm threshold. In these states, the worker was required to document that a child was harmed by exposure or experienced a significant threat of harm in order to substantiate. Just two states, Georgia and Utah, considered any exposure to domestic violence to automatically constitute maltreatment. While 36 states had at least one maltreatment type linked to exposure to domestic violence, only 12 states had maltreatment types explicitly linked to exposure, such as family violence harms the child, emotional abuse. And here's a list of the various maltreatment types we found linked to domestic violence across the state, just to show the wide variation in how exposure to domestic violence can be classified as maltreatment. And you can see here there's both abuse and neglect categories. We really think it's important that a state use a specific or an explicit maltreatment type linking it to exposure, because I think this really offers the opportunity for workers to receive some context-specific guidance in terms of making the substantiation decision. In just over half of the manuals, workers were instructed to identify a primary aggressor in cases involving domestic violence. And this reflects a conceptualization of domestic violence by most states as a pattern of coercive control, rather than discrete instances of abuse or domestic violence as bidirectional. Here's an example from Kentucky, which notes that field staff should attempt to identify a primary aggressor in cases where both parents are perpetrators of domestic violence. And our final category of interest was whether a manual included written protections against holding survivors of domestic violence accountable for failing to protect their children based solely on their own victimization. 11 manuals included conditional prohibitions, and I'll give a quick example of that, while 4 states included unconditional prohibitions against this practice. In this excerpt, you can see that the guidance starts out by stating that it is, quote, not acceptable to substantiate against the non-offending caregiver solely for the actions of the perpetrator of domestic violence. However, this prohibition is subsequently made conditional or qualified when the manual states that a non-offending caregiver could later be held accountable if they are provided help or support and then act contrary to the help or support that was provided to them. By contrast, the prohibition in the Oregon manual is unconditional, no qualifying language, and it notes that the adult victim should not be given an allegation of neglect related to failure to protect solely due to the child being exposed to domestic violence. In line with the research, scholarship, and advocacy that motivated our study, and based on our own findings, we then suggested a set of 4 quality policy indicators. This list was really intended as a starting point and was in no way meant to be kind of comprehensive or definitive, but just as a jumping off point for states to evaluate their own policy in this area. 10 states met at least 3 of the indicators, but we only observed all 4 of those in the Oregon CPS manual. So with that, I'll say thank you for the opportunity to be here with you today, and I look forward to our discussion.
Hello, everyone. I'm Damian Grasso at the University of Connecticut School of Medicine, one of the co-editors of the special issue. I want to thank our host, all the authors, my co-facilitators. I'm really excited that we can spend this time to give attention to what I think is a really real critical and complex set of issues. So the three papers we're discussing in this segment cover aspects of child welfare policy and practice that pertain to child exposure to IPV. As we heard, there's significant variability in how Child Protective Services defines IPV exposure in the context of child maltreatment, and how information about IPV exposure guides decision-making. And I really like these three papers because they focus on these issues from different vantage points and with different methods that include examining administrative data, qualitative interviews, and review of policy manuals. So there's already a bunch of questions. If I could just remind you to put your questions in the Q&A, and it would help me if you could specify if your question is directed at a particular presenter. Otherwise, I'll do my best. And we'll start off with a specific question for Rebecca that asks about the data pertaining to domestic violence being captured under the category of emotional abuse in California, given her or his anecdotal experience that it's often captured under neglect. And I guess I'll ask Rebecca that specific question, but maybe tack on my broader question that has to do with the pros and cons of Child Protective Services agencies having a kind of a broad independent category of IPV exposure versus subclassifying it under these different child maltreatment forms.
Yeah, thanks, Damien. So I think that the how it's classified as emotional abuse is in the statute. However, I think as the questioner asks, I think it is very possible that individual CPS workers could be classifying it as neglect as they approach a particular case. So I think what it highlights, and I think Damien's question is, is that there's not continuity, or it's not captured well in administrative data, IPV. And so I think that one challenge, when we see that 75% of nationally CPS reports, substantiated CPS reports are neglect, it's really hard to disentangle what that is and what that means. And so I think that one of the benefits of having a specific category that could be more specific and actually capturing exposure to IPV or whatnot could be better data and better understanding of what that means, as opposed to categorizing it as something broader as neglect or emotional abuse and not quite understanding what that actually means for kids and families.
Great, thanks. Elizabeth or Brian, do you have comments about that broader question?
Yeah, I can weigh in there. We make an argument within the paper for states to move towards adopting an explicit category for domestic violence. Some worry about whether or not such a move would expand or kind of increase the scope of child maltreatment involvement or CPS involvement within families' lives. But in our study, we found that about 90% of state child welfare systems already are making some linkage to childhood exposure to domestic violence within the maltreatment types that they have available. And I'll just say, in my experience working here in the state of Michigan, Michigan only explicitly connects childhood exposure to domestic violence to a maltreatment type termed threatened harm. And yet, when we actually look at the disposition summaries or the investigative summaries, we realize that the majority of childhood exposure gets classified as improper supervision or as supervisory neglect. So even absent some explicit guidelines to workers are using these kind of broad-based are broadly conceptualized maltreatment categories to substantiate both survivors and perpetrators for childhood exposure to domestic violence. So I think we're, our author group is very much in favor of an explicit category that really lays out some context-specific guidance to workers around the conditions under which they may or may not substantiate.
Thanks, Brian. Elizabeth, anything else to add on that?
Yeah, to follow on that, I think there would be some real advantages to separating out CEDV related allegations because in our experience and in our data, threat and harm it's a broad category. There are lots of things that workers understand to fall within that. And so the advantage of a specific exposure to DV related maltreatment type is that it would also potentially prompt workers to potentially follow specialized protocols for those cases in a way that linkage to a much broader maltreatment category doesn't.
Great, thanks. Actually, I'm going to skip around a little bit because I think this is relevant, a question about why Child Protective Services workers dismiss symptoms such as sleep, eating, academic performance, often seen with children witnessing domestic violence, and those ACEs studies that show domestic violence exposure as a risk for poor mental health. And I think it gets at that question of determining whether a child's witnessing IPV has that harm, that threat of harm, either emotionally or physically in it. And I just wondered this myself. If you think about more direct forms of child maltreatment, I think there's less subjectivity in determining harm than emotional abuse to witnessing IPV. And it gets at one of the indicators you mentioned, Brian, about whether we should keep that as a criterion for a CPS worker to identify threat of harm versus kind of adopting this assumption, I guess, that all children exposed to IPV are at risk for harm and have that immediately qualify. Also, I think it's a lot for Child Protective Services workers to have to do, especially without a background in and specialized training in clinical assessment. And I wonder about the tools they might need to do that. So that was a lot, but I'll turn it to you to comment on that.
Sure. So I think, this harm or threat of harm threshold for substantiating exposure to domestic violence really came out of kind of practical child welfare experience. I think, Minnesota back in around 2000 had classified any exposure to domestic violence as, in and of itself as neglect, and it really overwhelmed the child welfare system there. So I think there were some practical realities about treating exposure per se as a form of maltreatment. But I think there's also some legal considerations there as well. So a group of survivors from New York City filed a class action lawsuit known as Nicholson v. Scopetta. And within that, the court ruled that substantiating survivors solely on the basis of domestic violence was a violation of their constitutional rights, that you did need to demonstrate harm or threat of harm and kind of a pretty high standard for that threat resulting from the exposure. So I think it's a combination of those two things in terms of guiding a child welfare practice into the future. I will say also, I think threat of harm is in some ways a loophole. It's pretty vague as to what would constitute threat of harm. And so workers, in some instances, I think are continuing to substantiate exposure per se as maltreatment, given the broad-based and kind of vague language around threat of harm.
Thanks, Brian. Elizabeth or Rebecca?
I think, yeah, I'm going to agree. I agree with Brian, and I think that the threat of harm is one of those challenging things in terms. I think it's going to depend a lot about the court system. Oftentimes, so whether that's something that a judge or the judge that frequently hears the cases is going to accept or not, or whatnot. But as Brian said, I think it's something that's going to be very difficult to kind of prove, and I think that. some of the indicators that the questionnaire asks in terms of like sleep and eating and academic performance those can be difficult things to draw a direct connection between the exposure to violence and those outcomes, which makes it challenging for child welfare workers to intervene.
Following on what Rebecca said, in the data that we collected for our paper, one of the things that workers told us was that the standard for that sort of mental injury type is quite high and often required consultation with an external person, so a clinician, and that in the investigative window, right, the 30-day period that workers typically have to make decisions on cases, connecting families to someone who could complete that evaluation was often really hard. So I think that's one piece of it, is that there are practical issues that shape the kinds of decisions that workers make on the ground, regardless of what their intentions are, and certainly what they believe might be in the best interest of children.
Great, thanks. Yeah, so I would imagine there's a great degree of variability in CPS determining threat of harm, with probably the lack of tools and the expertise maybe to make those determinations and those connections to those mental health impairments that might be associated with that. There is a question specific to California, Santa Clara County, but I think more generally too, about Child Protective Services rarely wanting to take IPV witness reports, and as it's stated here, belittling mandated reporters of IPV witnessing. So this also kind of brings up a kind of a broader question for me too, about what should the threshold be in making a mandated report for a child that might be exposed to IPV, especially given that this is a contentious issue for domestic violence advocacy agencies and Child Protective Services. So maybe let's start with Rebecca, if you can comment on Santa Clara, and then others can chime in as well.
Yeah, so I can't, I don't actually know much about what's happening in Santa Clara County, but I know that, there's, again, there could be a lot of variability to in different locations based on, kind of what we've talked about previously about that, not only different thresholds, by, the individuals who are making the, like at the hotline level, and then also at the investigation level, but then also the judicial officers, et cetera. I think one thing that our research kind of highlighted was that there may not be services within the child protection system to best address some of the issues related to IPV. And that's what was one of the thoughts that we had when we saw, cases resulting in, substantiations, but not having a case opened. But so we thinking that, the child protection system might not be the best provider of those types of services. And I should just add, it maybe not be it could be a capacity piece too, right? Like the child protection system doesn't have services available or that address this issue, which also could be linked to the data issue of not knowing how many cases are related to IPV because we're not capturing that in the data.
Great, thanks. Anybody else?
I'll just comment that I'm sure that experience varies from county to county and system to system, but the best available estimates is that anywhere from and Rebecca's work that she's presenting today highlights this, anywhere from about 20 to 25% of cases involve exposure to domestic violence. And so I think these cases certainly are being reported and then screened through and considered for system response.
Thanks. Anything else?
I think just one last thing was our data did show that very few cases that had an indicator of IPV resulted in screen outs. So almost all of those cases are resulting in some sort of investigation, which I think indicates, at least statewide in in California that the presence of an IPV allegation are taken seriously and looked into further.
And perhaps only when they co-occur with another form of child maltreatment or rise to some threshold of threat of harm. Great, thanks. All right, let me go down the list a little bit. There's a couple questions for you, Rebecca, about numbers of IPV reports by county. Maybe you can respond, directly through typing, or another question about LA counties or other counties. Same question. So I don't know if you want to speak to that or just want to respond by typing your answer.
I can respond by typing.
Okay, great. All right, a question. When CPS offers resources, does anyone follow up on families participating in resources? I think this was brought up in a few of your papers, in your talks, about how sometimes those families that do have that differential response or are connected to services, often there's no kind of checks and balances to follow up on whether they're receiving those services. Any comments on that?
Yeah, I can speak to that a little bit. So in the data that we collected, many of the cases that involved child exposure to domestic violence were substantiated as, at least in our state, as moderate risk cases, which basically meant that CPS substantiated a caregiver, but then closed the case with a referral to services in the community. And so that meant that there really was no follow-up by CPS to either ensure that families made use of those services or to support them in accessing those services.
So in trying to be less punitive, perhaps, to the non-IPV offender, they're setting up a situation where maybe that family is not going to get what they need down the line. So how do we strike that balance between not being punitive, but also mandating certain services that we think are needed for a family?
Right, and then the tricky thing was that, for those families, because there often wasn't any meaningful intervention to address risk, right, those families would subsequently be re-referred, which could lead to a greater likelihood of substantiation. So absolutely a missed opportunity for an early and non-punitive intervention.
Great, thanks. Any other comments on that? There's a question about CPS workers being trained on domestic violence exposure in children. And I think this might also get at whether they're trained to kind of understand what that threat of harm means. This was specific to California, I think, but I'd be curious to hear what you have to say in your areas. I know here in Connecticut, we have a newer program where there's a core set of caseworkers that had received specialized training in domestic violence and serve as consults to other caseworkers. So curious to hear what you have to say about that.
I can start. I think that's a place that is a little unclear of, at least in California, because it's a county run. So each county runs its own child protection system. So it's unclear of how much training there is, but I think one of the hopes from our research is that seeing that so many cases do have allegations of IPV, and knowing that these, from previous research, that these kinds of cases can be very complicated and complex for workers to navigate, that increased training and specified training is definitely needed.
Thanks. Anybody else on that?
Yeah, I think, of course, training is a perennial challenger issue for child welfare, given high rates of turnover. And so it's something that needs to be done repeatedly. And, in reading Elizabeth's paper and thinking about training as kind of one tool for moving families towards a supportive framework, but also thinking about policy and policy contradictions that might exist within a system, and really starting to use policy as a means for ensuring supportive responses within the system. So, as with my paper and in general, just a plug for policy as a tool for moving us towards new ways of practice.
Thanks. Question for Brian. I believe this pertains to that slide about the conditional criteria. Imagine that those in quotes, necessary supports offered under the conditional are quite varied. For example, severing the relationship, shelter utilization, etc. Does that question make sense to you?
Yeah, the question makes sense to me. I think, certainly it's the data we collected in the study, it doesn't really allow us to know the types of supports that are offered to non-offending caregivers across various systems. But I think the data that do exist oftentimes suggests that the number one kind of prescription or safety plan moving forward is for survivors to separate from the perpetrator. We heard in the last session, and what the evidence suggests to date is that separation is really a potential time of heightened risk and potential harm for both the survivor and child. And so I think it may be, might consider it contraindicated to suggest separation kind of as across the board. Certainly there may be times when that is the best way forward, but in some cases, I think that really can do harm. And the condition that, these conditional kind of protections in some ways put survivors and non-offending parents on probation, right? The case moves forward, they're given this instruction to separate, and then absent other supports such as housing or concrete supports that would allow, may potentially allow for separation, they do find themselves back in contact with the child welfare system, and upon subsequent re-referral are oftentimes then substantiated for neglect. So I think we need to really think critically about the service array and types of supports that we offer to non-offending caregivers, and whether they're really kind of domestic violence informed in terms of thinking about coercive control and what's needed in order to secure safety.
Great. This kind of relates to something I was thinking about after hearing Elizabeth and reading your paper. One of the cases in your paper described kind of this unreasonable assumption of safety plans of cases that don't go on to involve partner separation, that adult victims had sufficient control over the violence to prevent it from happening again, or that children who do not physically witness IPV are not harmed. And given this move to needing to make perpetrators more accountable in the case where families are intact, what would be a more reasonable safety plan for these cases, and what role should CPS play in supporting that safety plan, and maybe even domestic violence advocacy groups? Any thoughts on that, Elizabeth or Brian or Rebecca?
Yeah, I can offer a couple thoughts related to that. I really think that the gist of the supportive framework and really moving away from punishment is to shift our focus in case conceptualization and assignment of responsibility and in service planning onto the perpetrator of domestic violence. Even some judges have suggested in court rulings that the focus really be on potentially removing the perpetrator from the home as one potential option rather than children. But of course, that's a more severe level of intervention. I think really the attention needs to be shifted towards perpetrators and the types of supports that are needed for them to cease harm and cease abuse. So I'll just as a plug for moving away from a focus on all the things that non-offending caregivers might do and shifting our attention over to those who perpetrate harm.
Great, thanks. Anybody else?
I think making sure that perpetrators have access to services is an important piece of preventing future instances of intimate partner violence, and something that we we heard used less frequently by the workers that we spoke with than we might have hoped. So often the perpetrators ended up sort of maybe referred to services in the community, but we know that sort of research on partner abuse intervention programs for perpetrators suggests that people rarely access those services absent a mandate from their criminal or a family court. So sort of suggesting that folks access those on their own is unlikely to lead to behavioral change. And at the same time, when the perpetrator is separated from the rest of the family and there's no longer a child in the home, in our state, child welfare workers sort of lost that leverage to compel services. So kind of figuring out how to make sure that there are policies in place that allow for those services to happen, sort of independently of where the child is and independently of the status of the relationship, seems like a good starting point.
Great points. Rebecca, anything to add on that?
No, I think they covered it well.
All right, good. There's a question that kind of goes back to a previous part of the discussion about whether we need an assessment of degree of risk or harm, such as having an outside evaluator when considering exposure to IPV as harm to the child, as well as maybe a psychological assessment. I think this kind of gets to resources and timing. Anything further to add on that topic? And I certainly would agree that we need to establish better tools for caseworkers who, again, don't have that level of training. If they're the ones making those determinations, I think we need to equip them with tools where they can really guide that decision making. And I know that's not the case in many places.
Yeah, I think I would just add, in response to the question about having a specialized evaluator, come in, that's probably not an available resource at the volume that's needed, that we're seeing in the number of cases that are coming to the attention of child protection systems. And so it's a resource problem, I think, and I think that, highlights Damien's point of, that better training needs to be in the hands and resources in the hands of the CPS workers, where they're going to have to make those decisions in a relatively short amount of time during their investigations.
I would suggest supports as well as training. So in the state where we collected our data, there was a specialized domestic violence assessment tool available to workers that they were meant to use in cases where there was caregiver intimate partner violence. However, they didn't use it. They used the structured decision-making risk assessment because it was built in to their investigative procedure. For them to use the specialized domestic violence assessment, they would have needed to take it upon themselves to do that, and then to try to figure out how to combine the results of that assessment with the results of the SDM. So I think there's a policy response that involves, if we want workers to do this, then we need to make it really easy, right? To make sure that the assessment procedures that are, the best for folks to use are the ones that are integrated into existing workflows.
Yeah, that's great. Great point. There's a comment here about CPS often not utilizing community clinic services, and a related comment about our question about why CPS doesn't work with mandated reporters to look at follow-up for services. That might be primary care physicians. For Rebecca, I think you found that law enforcement was the primary mandated reporter. And I was also curious about, what role, whether it's that they follow up with services or not, what role we might see for mandated reporters, especially if law enforcement is playing a major role in that.
Yeah, I think that, that one of those kind of considerations that CPS workers are often managing is the privacy concerns of the families. And so, and I think that what ends up happening, that oftentimes if that is a prioritization for the CPS worker regarding the family, that can feel like to folks who, professionals in the community, that they are being excluded from the process and whatnot, when I think that that's not necessarily the intention, that oftentimes it's more in regards to privacy. But I could see how that can be seen. And I think that's just one of those general challenges of, the system and trying to balance a myriad of folks' priorities that are involved in things being very sensitive.
Right. And there's a follow-up question for you, Rebecca, about law enforcement. I lost it. What information goes into whether law enforcement makes a report? I'm sure that depends on where, but where you are, what goes into that?
Yeah, unfortunately, that's something that we didn't really look at in this case, but I think a follow-up that we are interested in doing is, looking if there's geographical variation, because we suspect that, different law enforcement agencies may be more likely to report to CPS than others.
Right. Okay, great, thanks. Question that asks, will the panelists have comments about the California ACEs Aware policy promoting ACE screening on children in primary care settings? Further, physicians are not equipped or trained to handle disclosures of ACEs related to domestic violence or child abuse. I might also add that there's, there's two sides of it. There's an active debate about screening for ACEs that we see in the literature. So any thoughts on that?
Yeah, I think that's a huge challenge. So just like, we're talking about CPS workers, not necessarily having the training or resources to handle, domestic violence at the volume that they are likely handling it, that I think that even more so for, could be a challenge for ACEs screenings for pediatricians, not only in their training, but then do they have the resources to refer kids and families to the services that are needed once they are aware of, challenges going on.
Right, I might add to one of the debates in the literature is that, there's a myriad of services that potentially could be related to ACE exposure. So we would be, it'd be necessary to train them on that, of course. Brian, Elizabeth, anything else to add on that? All right. Question here. Clearly delineating categories of IPV and maltreatment seems advantageous from a research perspective. Would love to hear presenters' thoughts on the policy perspective and how we as researchers can facilitate CPS's buy-in of coding specific experiences in a reliable way. How do we bridge that gap and communicate that?
Oh, go ahead, Rebecca.
I was just going to say that I think that there, that putting on, when I was a CPS worker hat, that there was oftentimes that we were hungry for information. And so I think that presenting it as a partnership and being able to answer questions that the CPS agency may have could be helpful. And so treating it as a partnership and whatnot could be helpful to get the buy-in.
Great, thanks. Another question, stating that physicians are not trained to deal with IPV and child maltreatment does not help collaboration. Why does CPS do this type of stereotyping? I think maybe that statement, feel free to jump in. I think that statement has to get to the need for these cross-agency, this crosstalk between agencies and different child serving professionals and providers that just isn't there. And I think that's, I think every state is kind of struggling to figure that out. Any comments on that? And then we're getting close to wrapping up. And a question about, we often talk about caseworkers and what they need to do. Have any of you seen a team or community response to assessment and intervention with IPV and child maltreatment?
I can mention that, LA County has a work group that's happening at a kind of a broader level of bringing together a variety of different folks from different agencies and workplaces to talk about the challenges of the intersection of maltreatment and IPV. And I think, even just starting those conversations and having those, can lead to productive and changes and whatnot.
And I actually think one part of the solution, at least, is finding inroads between Child Protective Services and domestic violence advocacy agencies. Like I said before, often do have some contention in their decision making, and kind of building a bridge and finding ways to collaborate and utilize community resources would be a good step forward. I want to thank everyone in this segment and overall, this has been a great day of talks, and I think we really kind of pushed the envelope on this topic. And I will turn it over to the host to close things up. But thank you.
And I actually think that that's me. So I think we are at time. So just want to thank everyone for coming and engaging. We will be posting information, the recording of this on the APSAC's YouTube page. So look for that. And again, thanks for everyone for participating, from the panelists and our facilitators. And I just want to give a big, huge shout out to two of our student workers who helped facilitate this, Lily and Rachel, who are really instrumental in keeping everything organized. So thanks to them. Thanks, everyone.